Thank you to the speakers. We want questions. We want questions. Doc- Doktora Kakacho. Okay, if there are no questions, I will ask one question. Regarding, nasaan na si Doktora sa end-tidal CO2? Doktora Xiao? Doktora Xiao nag... Okay. Regarding the end-tidal CO2 being a part of a basic standard monitor, when was that agreed upon? When? Kasi hindi ko nga alam yan eh, na basic na pala yung end-tidal CO2. And I'm sure some of you, especially those practicing in the provinces, still don't know that. And those practicing in the government institutions also do not have end-tidal CO2. So what would be your advice, and when was it a standard monitor? Agreed upon as a standard monitor? Or maybe we can change the standard of practice in anesthesia, because the practice guidelines in the anesthesia practice does not mention end-tidal CO2 still as a standard basic monitor.
To answer that lengthy question, a very specific question, Laura. The end-tidal monitoring was first approved or recommended by the American Society of Anesthesiologists in 1995 as a basic monitor for ventilation for all patients undergoing general anesthesia. But it was amended in 2011 that all patients who are given moderate or deep sedation be also monitored. The other question was how, when do you, it's actually written in our book in Barash already.
So that's 8 years ago already.
Yes.
So what would be your advice to those who do not still don't have magpabili? Pero wala nang pera eh.
We're very resourceful, so increase your O2 flow.
Yes.
To blow off the
You
CO2.
increase your oxygen flow.
Yes, but it would be more costly if you're using volatile anesthetics. You'll be consuming more.
So you mean to say, Doctor, even if the patient is under spinal or urachal, we can put the end-tidal CO. It is also already considered as basic.
No, only if you gave moderate to deep sedation while you do the spinal anesthesia.
Oh,
So GA or moderate
deep.
or deep sedation.
Okay, deep to moderate. Okay. So, papabili tayo. Ay, Doktora, magpabili ka na. It is already a basic. So, regarding temperature monitoring, would it be beneficial also to shut or to close or patayin yung aircon? Kasi yun ang practice ng iba eh. Pag giniginaw yung patient, ay patayin na yung aircon.
So, I think about 3 years ago, Dr. Valera actually gave a very good lecture on why the temperatures of our operating rooms are cold. So, it's actually number one, to avoid infection, to avoid growth of bacteria, contaminating bacteria. And the third is to protect our instruments and whatever equipment that we use in the operating room. So as you can see, nowhere in that lecture, and it was evidence-based, okay? So nowhere in that lecture did it say that temperature is maintained cold for our surgeons' preferences because of their gowns. No? So if your institution will allow you to turn off the air conditioning, if the air conditioning is per room, then by all means, yes, that will be helpful. No, but as I just briefly mentioned it, showed it in the slide, the radiation and evaporation are the highest forms of environmental heat transfer. Also during general anesthesia, so that will definitely help.
How about the EINC, Tara? The EINC, they require the the operating room not to have an air condition after the delivery of the baby.
I think, I am not sure po, Dr. Rano, but so far in the hospitals that I practice in, the ENIC does not require us to turn off the air conditioning in the room so long as we have a dedicated warmer for the babies. No? But again, if I'm sure there are institutions where a drop light is being used to warm the linen and the bed where the child will be placed, then by all means, if you are allowed to turn off the air conditioning, then please do so.
Because about 8 years ago, when they started the EINC, the people from DOH came to the operating room, and they were the ones who said you have to put up. And then I went beside the aircon just to say, sarado na po yan, because we were already talagang hyperthermic na. So that is yung ng EINC. So, Doctora, for the invasive monitors, basics and beyond, would you recommend putting all those gadgets in a very, very short procedure to a critically ill patient?
If the patient is critically ill, the duration of the procedure should not matter. It is always should be the priority should always be the safety of the patient.
Yes. How about, for example, gastroscopy, endoscopy? Sometimes, they will not sasabihin nung sandali lang to eh. Okay na yan. But the patient already is bleeding, pangit na yung ejection fraction niya. Pwede naman, yung iba nakakaraos. Di ba, Doctora? So, yes, I agree with you that kahit na 2 seconds, Doctora, kahit
I think we have to fight for our patient, for our
Yes.
patient safety. We cannot rely on our luck na nangyari before successful because we never know when the tragedy might come.
yes. Ay, yes, sir. Question.
Doctora, regarding end-tidal CO2, sometimes I have patients who has a increased ETCO2 intraoperatively. I just want to ask, when is the red signal to shift to or to turn off the the trigger for MH? Because I had already I had 3 cases of MH already. So I don't know if when to stop the anesthetic because of the increase in end-tidal CO2.
From what I remember, since you work in a malignant hyperthermia prone area, the increase in end tidal would be the first sign. So I think you need a higher index of suspicion. If that's the case, you can switch to TIVA already.
Yes, but what level of ETCO2 should I be alarmed?
Okay. So
When should I be alarmed?
so the normal arterial CO2 level is 35 to 45, right? So the end tidal CO2 is actually 5 millimeter mercury lower than that. So if it's not just a question of ventilation, it's also a question of your acid-base balance. So if you're increasing CO2, you will have acidosis and eventually there's cardiovascular collapse. And since you have a high index of malignant hyperthermia, I don't think you should wait longer. So if steadily increasing, maybe for the higher normal value is 50,